I'm Dr. Fiona Lovely, and this is the Not Your Mother's Menopause podcast. I'm taking the taboos of menopause and perimenopause and bringing light to the dark. No bullshit, no shame. It's time for us to gain a new paradigm in female health, out with the old and in with the new, and I'm bringing fresh perspectives from someone in the arena. I've been practicing women's health for nearly 20 years, and I'm spilling the tea on what it means to live at midlife, knowing that the best is yet to come. I'm sharing my Gen X approach to living through this transition. Sassy, a bit sweary, and always honest. Tactical tips and instantly usable information is my aim. I hope to make you laugh and that you learn something new that helps you embrace the change. Together, we bring power to the peri. Onward to the podcast. Welcome to the Not Your Mother's Menopause podcast. I'm Dr. Fiona Lovely. Thanks for joining me today. I have a really exciting interview today. I so enjoyed the time I recently got to spend with Baz Moffat. Baz is a former Team Great Britain Olympic rower, retired from sport to launch a successful international consulting and coaching business. A prominent voice in the women's health movement, Baz specializes in the pelvic floor, a pivotal yet vastly underappreciated nucleus in the female body. She is the author of the Female Body Bible with Drs. Emma Ross and Dr. Bella Smith. She's the co-founder of The Well HQ. She has a master's in sports science, and her jam is female-specific issues in sport and physical activity. Man, did we have a good conversation. So I do want to let you know that we do talk about trauma, sexual trauma, and the pelvis. So consider this your trigger warning for sensitive ears. And I think it's pretty obvious when that's coming, so you can skip over that bit if you wish to. But as always, if you're interested in seeing the video version of this and all my interviews, you can join my Patreon page, just patreon.com/Dr. Fiona Lovely. The link's in the show notes. And then you get to see our faces, which is kind of a fun thing. Now, before I get on to speaking to Baz, I think you're going to love this one. Please take a moment to listen to our sponsors. I would like to acknowledge our sponsor, Athletic Greens, which is now called AG1. This is a vitamin, mineral, and probiotic greens drink. It helps me boost my energy and gives me the nutrients I need in case I don't get what I want and need in my diet for the day. It tastes great, and it has mushrooms and digestive enzymes and adaptogens for adrenal health. I take it once a day. It's truly an all-in-one supplement. If you would like to try AG, please visit athleticgreens.com/Fiona Lovely, and they'll send you a year's supply of liquid vitamin D3 with K2 and 5 free travel packs, which come in mighty handy for getting your AG on the go. Thanks, Athletic Greens, for sponsoring the Not Your Mother's Menopause podcast. All right. Welcome, Baz Moffat, to the Not Your Mother's Menopause podcast. I'm Dr. Fiona Lovely. Welcome.
Thank you very much for having me.
Well, I'm excited to talk to you today. Of course, we came to just know each other from a mutual friend who's Patty Hall. She says we have lots to talk about in common, and I think she knows our work well. So
yeah, I'm sure she does. Yeah, she really does. She was very excited when she made the introduction.
She sure was. So you and I got some magic to figure out together today. So let's do it. Let's talk women's health. So tell me about you, please.
God, that's a big question. I won't waffle on for too long. But In a nutshell, my background is in sport. I've loved sport since the moment I came into this world. I made it onto the British rowing team in the women's 8 in my sort of late 20s, and then so that, you know, that was very much eyes on the prize, fully focused, driven. I know exactly where I want to be and how I'm going to do it. And I thought, oh, I've cracked it. I've cracked life. I know like how to achieve. I know what I want to be doing. Stopped rowing, went into personal training and fitness, loved it, loved coaching, and got married, had 2 kids, and it was incredible. It was I had, you know, 2 children, 2 very, very contrasting birthing experiences. The first one I approached like an athlete. So I approached it as in like, I'm great, I'm physically very capable, whatever I ask my body to do, it does, I'll be fine. And that was a car crash of a mindset to have. And like the effects of that, just that arrogance, like that arrogance was like, I had no ability to cope with like the physical pain that happened with my birth, with the birth of my first son. And it took me years to get over that. Had another child quite quickly, worked with a doula, we call it like in the UK, like a doula, and it was kind of like a mother's support, if you like. And the contrast in the 2 birthing experience was extraordinary. And it was the first time in my life that I tapped into the power of being female and the power that your body can have if you allow it to do it. Like up until that stage, I told my body what it needed to do every step of the way. I hadn't really tapped into all this incredible power that it had. And I had this amazing birthing experience with my second son. And it was honestly at that moment where I was like, oh, I don't know how I'm going to do this, but like the female body is extraordinary, and we need to know a lot more about that. And we need to not just access that in birth, but we need to access that in health and fitness, in sport. And that's what I kind of like, after Cooper was born, I was like, right, this is what I'm going to work out how to do.
Beautiful. So how exactly do you do that on a daily basis?
Yeah, how do I do that on a daily basis? So after having Cooper, I stayed within the world of fitness. I stayed within the world of personal training, but got very focused on pelvic health. So I kind of worked like with loads and loads of women, not just in that pre and postnatal phase, but menopausal women that were sporty, women that were high performing athletes, women that had experienced quite a lot of trauma in their lives. And I really, really adored it. But I knew that the conversations I was having on a day-to-day basis was like, this isn't okay. Like, this isn't okay that women are having to come to me to learn really, really basic stuff, like literally how to go to the toilet. Like, I'm like we should know this. Like, we shouldn't have to go and pay an expert to learn this. We shouldn't have to pay an expert to learn how to do a pelvic floor exercise. Like, this should just be part of what we know because we're women. And so I was like, someone needs to do a better job. I don't really see anyone else. There's lots of brilliant people out there working in their own little kind of populations, but I didn't see anyone doing it on a grand level. I was like, well, I'll give it a crack. And I hooked up with 2 of the doctors who were absolutely fantastic in their field. And we're just on an absolute mission, really, to educate women and girls about their bodies so they don't hold them back, and then educate those sports coaches and those PE teachers and those fitness trainers who are supporting girls and women about girls and women's bodies.
So we have women listening right now that are going, did she just connect sports and pelvic floor health? Tell us about that, please.
Yes. So did you know that sports people have higher prevalence rates of dysfunction than the normal population, which is not a usual statistic when it comes to the body. So if you look at anything else like muscle strength, power, cardiovascular health, like anything else, it's generally positively correlated with your levels of physical activity. So the more exercise you do, the healthier you are. Now, obviously, that there's a point where that doesn't happen, but most cases, our bodies are pretty respond brilliantly to physical activity. However, when it comes to pelvic health, that's not the case. And especially when you add into the mix being female, aging, so menopause, and children, and high impact sports, when you add impact at any level into that mix, the prevalence rates are really, really high. And we're talking 50, 60, 70% of a population who will be leaking during training or competition or just exercising. And for people like me who were like born into this world to be active, like it doesn't stop me. It bothers me, but it doesn't stop me. But for those people that like don't love sport, don't get that buzz, know they should do it, but they don't really want to, like it stops them because that's like, no, there's no way I'm going to do this because because I leak or I'm in pain and I'm uncomfortable. And yet there's not really very much support out there to help women in that space.
So menopause care, women's health care, and pelvic floor care are all having a moment right now. And it's about damn time, right?
Yeah, exactly. Right.
So I love what you're saying here. We're actually sort of pulling back the curtain, which I love to do on this podcast, with the taboos around perimenopause in particular, which is 35 to 55. Typically, it's somewhere, women are going to be somewhere in there. So when you say pelvic floor dysfunction, please tell us what that means for women in the perimenopausal era.
Yeah. So I think let's take a step back and I suppose like just explain, like the pelvic floor is supposed to keep us dry. That's its job. It's like the roof on your house. It's supposed to keep you dry. You don't notice that the roof is doing a great job. You don't go, oh my goodness, the roof did a great job today. It's like you only notice it when it's not doing a great job. And I think that's, so we just kind of like it's kind of business as usual, means it's working fantastically. When the pelvic floor goes wrong, it's leaking. It's leaking when you're laughing, coughing, sneezing, or when you are doing exercise like jumping, landing, twisting, turning, running. It's having irresistible urges to empty your bowels or your bladder when you don't want to. So we should always be in control of when we want to go to the toilet. So we get an urge to go to the toilet and we go to the toilet and we sit down on the toilet and everything comes out and there's no panic or anything like that. But at certain times in our life, at certain times of our menstrual cycle, sometimes for some women, they have these irresistible urges. And if you are if you're a runner or you love exercise, and you start to get these, then your enjoyment of that physical activity is really negated. And we find, especially when it comes to menopause, that these symptoms can be amplified and can come on quite quickly, whether you've had children or not. And so it might be like, nothing's changed. Like I've never had any problems with my pelvic floor. Why suddenly, doing exactly the same stuff that I've done in my life, am I experiencing these issues? Because of the estrogen roller coaster, and because the fact that the vagina in particular and the pelvic floor needs estrogen. It is densely populated with estrogen receptors, and those receptors need estrogen to keep it plump, to keep it moist, to keep it functioning, to keep the muscles strong. And if the estrogen isn't there, then that's why suddenly women will enter midlife and they will get pelvic floor dysfunction. And the other symptom is prolapse symptoms. And when I mention that word, some people just wince and kind of cower away and are like, do not talk to me about that. It sounds disgusting. It makes me feel like everything's about to fall out of my body. I don't want to know anything about it. But I believe, like you, thinks that knowledge is important and we need to have this knowledge. And a prolapse does not mean that everything is falling out of your body. You can have a real kind of like low level prolapse, which just comes on at the end of the day or after an exercise class, but you go to bed, you lie down flat, gravity sorts itself out, and the next day you're kind of okay. But again, when you get to menopause, like post-menopause, the prevalence of prolapse is much higher. And actually, when I just mentioned the fact that the pelvic floor isn't always positively associated with exercise, we don't know. Women exercising is a really new concept, and I think we forget that. Like women actually haven't done high levels of exercise for very long, so we don't really know what are the consequences of this. And I think that my prediction is that actually we're going to be doing a lot more preventative pelvic health work as opposed to reactionary pelvic health work. So we are going to be talking to our 20-year-olds who love CrossFit, who love training hard, who love competing, about the fact they need to be doing much more preventative work with their pelvic floor, because we are living for so long post-menopause without estrogen that we have to take better care of it if we are doing this high level of work.
Absolutely. And so I love this prevention piece. And I interviewed a pelvic floor surgeon on the podcast before. I think I told you I hadn't, but I forgot about that one. But her and this is Dr. Teresa Irwin. She calls herself the vaginacologist, and her whole philosophy is I never want people to be in my office. If I can give them the information way ahead of time, and they never have to be there. And that's exactly what you're talking about. And
yeah,
you know, you hit on a couple of really, I think, big button topics. Is that women historically didn't do that high level exercise, right? Number one. Number two, we've got a data gap in the research about what happens to a woman's body, especially considering all the hormonal cycles, et cetera, and or menopause, how we train differently, how our performances as the hormones wax and wane. And then we've got just this amazing ability to see everything now and say, okay, where are the gaps? A woman lives 40% of her life after she has her last menstrual period. And, you know, the other thing we have to remember is that women, maybe 100 years ago, we didn't live long past menopause. So there wasn't
I think the average age was 45. So we never even got there. So menopause in itself is a concept that's never even existed, because, you know, once we're done with having babies, like there's no, you know, it's all right, job's done.
Yeah. And I think there's a discussion for like, why is it some women don't have menopause symptoms, and some cultures don't even have a word for menopause? And the truth is, it hasn't been that long that women have actually seen the other side of what happens at menopause. So let's get back to the pelvic floor. So I love everything you just talked about, but Baz, doesn't Kegels just take care of that for me?
Right. So there's nothing wrong with Kegels. Kegels are great, but most people don't even know how to do them. So like, that's a problem. So like, you know, we are not born, we don't know how to do exercises. So I think that especially the classes that I'm going to now, they'll say, oh, and connect the pelvic floor and squeeze the pelvic floor and lift the pelvic floor and do your pelvic floor. And the trainer will think that's enough. And you're like, but no one in this class has a clue what you're talking about, because we don't know how to do it. So Kegels would be a great start if we actually knew how to do them properly. But if you are doing them properly, yes, but most people will do their Kegels lying down or sitting down. Most people do not have pelvic floor issues lying down or sitting down. They will have pelvic floor issues when they're standing up, when they're moving, when they're jumping, when they're landing, when they're coughing, twisting, turning. So we need that Kegel to be integrated into our lives. And that's not what's happening. So it's almost like that's a starting point. But however, if you're an Olympic gymnast, for example, 90% of gymnasts will be wetting themselves during training or competition. Now, a Kegel is not going to help an Olympic gymnast, because she is putting so much force through her body. She needs to start there, but her pelvic floor work needs to be Olympic level too. Do you see what I'm saying? Like, it's kind of like a Kegel's not going to be enough. Now, I don't imagine many people on this listening here are going to be Olympic level gymnasts, but they may well be basketball players or playing football at the weekend, or like going for little runs and things. And however hard you're training the rest of your body is kind of how hard you need to be training your pelvic floor. So the Kegel is just a start.
Okay. I love this concept of the Olympic level pelvic floor. Please tell me that's going to be your next book.
Yeah, I would love that too. And I think that it's the, you know, I've just literally, just before coming on a call with you, I've just been teaching 50 personal trainers on a Zoom about their pelvic floor. There was 25 guys, 25 women, and they worked for a big gym chain in the UK. And I was teaching all the men how to do their pelvic floor exercises, but actually they were, you know, it's like, well, how do we teach a woman to isolate that part of her body? How do we teach a woman to feel that part of her body? Like, I've explained how I've got to this stage when women experience trauma, and it's not necessarily a birth trauma, but trauma in their lives, it's often around their pelvic region. It's that part of their body, and that trauma stays there. And so if you can't just teach a woman how to do a pelvic floor exercises like you would do a squat, because they've got to feel a part of their body they might be really ashamed of, embarrassed by. It may well have been violated. It's so complex, and you've got to get through all of that emotion and give her a really safe place where she feels safe before she can get anywhere near accessing it. And I think that we can talk about Olympic level, but often often to get anywhere near the continuum, you have to do quite a lot of work, and that might not necessarily be physical work to even get to a place where you can access this part of your body.
Right. So in total plain speak, lots of us carry the trauma of our lives in our pelvis and in our low back too, but primarily, you're right, for women it's the pelvis, and it may require a mental health professional to help you through
but it's connected. The lower back's connected. It's all like with your bowel health, like they're all constipated, like the whole thing is connected. And if you lying a woman down and you say, right, we're just going to breathe, and you're like, tell me what you feel, and they're like, nothing, you're nothing. Like just tell me what you feel. Like, let's just give this a moment. Like, let's just lovely, soft, gentle, deep inhales and exhales. Where do you feel this breath? Nowhere. Like, and you're like, okay. Like, so they can't get, and this isn't people with massive trauma. This is like normal everyday women are just like, nah, I can't feel a thing. And so they're going to the gym, they're doing their sport, they can move their arms and their legs, but nothing is going through their core because they just can't connect it. And I think that, especially at the middle age spread, the menopause, whatever, the menopausal tummy, all that kind of stuff, it's like unless you can feel that part of your body, we can't do anything with it. And I think that people underestimate the amount of work that has to go into kind of like getting into that place.
Absolutely. And the research is showing us now that the ancestral trauma goes back 7 generations minimal. So if you and I calculate what we know of our families and what they were going through at that point in their lives, there was nothing but wars back then, right? Right. Or ethnic cleansings, or women burned at the stake and that sort of thing, right? So whether a woman is able to identify what her trauma might be or not, we still carry it. And, this is a deeply sensitive part of the body. So can you tell us what the pelvic floor is?
Yeah. It's a group of muscles and ligaments. Like, that's it. Like on a you looked at it under a microscope, it will be exactly the same as any other sort of piece of connective tissue in your body. It attaches to your coccyx bone at the back and your pubic bone at the front, and it's like a hammock. So that's the best way of describing it. And it holds up the weight of the bowels at the back, the uterus in the middle, if you have one, if you haven't had a hysterectomy, and the bladder at the front. And the reason why it's a nice way to describe it is as a hammock, because you, like, when you visualize a hammock, you know that if someone got into a hammock it would give, and if someone got out of a hammock it would come up. And that's what the pelvic floor is. It works beautifully with the diaphragm. So as long as you've not closed it off and blocked it off and not doing anything with it, as you inhale, all your internal organs will descend, because the lungs are filling up with air and the diaphragm flattens out. Those abdominals come down towards the pelvis, and that pushes the pelvic floor down. And then as your breath comes out, in the abdomen all comes up, and then that draws the pelvic floor up. So it's a dynamic muscle. And I think that when people are listening to us talk about pelvic floor, there'll be many women who have just like started lifting their pelvic floor and are trying to hold on their pelvic floor. We've been talking about this for like about 5 minutes now, and it'd be kind of like, no, that's not how it works. It's not, you don't like get it on and hold it on and like try and squeeze it forever. It works with the breath, and that's why the breath is so key when kind of accessing this part of the body.
Well, in my very rudimentary understanding of how the pelvic floor works is that for a lot of women, the problem isn't a strength or a flaccidity, which is what we think. It's a looseness. I mean, that's what society has sold women. Once we get to a certain age, once we're menopausal, once we've had kids, all of that stuff, which, we could have a whole conversation about that BS, but we won't. It's more about muscle spasming and dysfunctioning, in which case, if you're just doing a Kegel squeeze, it's not really going to give you the
No.
same, it's not going to give you the outcome you think it is.
Yeah, and this is a really interesting conversation because I don't want to scare anybody from doing harm to their pelvic floor by doing the wrong thing. So I think that it's very easy to kind of like talk about getting it wrong, or oh, maybe you've got a tight pelvic floor, or maybe you've got a pelvic floor that's uncoordinated, and so like, oh, it's really complex and confusing. Now, the biggest trauma to a pelvic floor is childbirth. Vaginal is labor and childbirth. You doing your pelvic floor exercises incorrectly for 2 or 3 weeks, it's not going to make that much difference. Like it might not positively have an effect, but it is not going to give you a prolapse. It's not going to kind of like create massive, like irreparable damage. So what I recommend to everybody is like, start doing what you perceive to be a pelvic floor exercises. Just give it a go. If you just give it a go, if after 3 to 4 weeks, 0 has changed, then go and see a health professional. And then at that point, they will be able to do a full assessment of you, and they will be able to really accurately analyze, is your pelvic floor too weak? Is it too strong? Is it uncoordinated? Is like the left-hand side stronger than the right-hand side? Like all of this stuff, they will be able to piece the whole thing together. But if you know, I have worked with women who have a tight pelvic floor, they are leaking. So they're like, oh, I must do more exercise. They keep squeezing, and they're doing hundreds of these Kegels every single day, and they do it for months and months and months. Then that's a problem. But if you just do it if you're doing like a set of 10, 20 exercises a day, after 2 or 3 weeks, you're like, yeah, that's not really improving. Okay, I'll go and see somebody. Like, it's fine. It's not a problem. They might say, God, you know what? You need to really work on relaxation. But that work you've done it's not childbirth. And I think that, you know, I work with women who have such little confidence about their bodies that scares them so much that they'll get it wrong. They do nothing, and actually doing nothing, like they won't move at all. They won't do any exercise. They won't go to a gym. They're so worried about injuring themselves, doing heart, etc., that they just stop. And actually, our bodies are really good. They're resilient. They're not fragile. They're fragile. They can be fragile at certain times. But I think if then we have to have this belief that they're not going to break, then that we, you know, that we have to support them and be really positive about it.
Yeah. Much coming to the surface, right? There's so much in society coming to the surface. It feels like it's coming through the female reproductive organs for whatever reason. But again, different conversation, different day. So tell me, is the pelvic floor involved in orgasm?
Yes, it is involved with orgasm. So I've worked with women who really said that, like, oh, since doing their pelvic floor, because they're connected to it and they can feel it, that actually they have much better orgasms, and they're much more intense than they had done previously. And I don't know why. Like, I think there's lots of different theories as to why, and lots of people have kind of got their own take on it. Mine is that you're daily connecting to that part of your body, and it kind of like, and therefore the neural pathways are better connected. So for sure, like, people have reported that you know that their sex life massively improves since they're doing their pelvic floor exercises.
Oh, fantastic. I mean, anything that gets a better orgasm or multi-orgasms for a woman, I think is a good thing.
Yeah.
So the reason why you and I are here today is really to talk about a new baby you've just birthed.
I know. Yeah, it's taken a lot longer than 9 months. I can tell you that much.
It's called the Female Body Bible, and it has just been released in the last week. Is that correct?
Correct. Yeah. Just over a week ago. Yeah.
Fantastic. So everything that you've just talked about is in this book in some way. Is that correct?
Totally. Fantastic. Yeah, it is. And I think that so I wrote it with 2 doctors, a academic doctor and a medical doctor. And it's called, the Female Body Bible. What we fundamentally believe is that there isn't a fix, there isn't an app, there isn't an exercise, there isn't one thing that everybody needs to know or do when it comes to female health. We're not at that place. We need to educate girls and women about everything to do with female health, and then allow them to make the decisions that are right for them. So this book covers a real breadth of topics, from everything that you'd imagine was in there. So from menstrual cycles, hormonal contraceptions, breast, pelvic health, all the things that happen exclusively to a woman's body, so all the life stages that we experience, but then all the things that happen differently inside a woman's body. So and it's all connected with sport and exercise. So nutrition, our relationship with food, how our bodies, how our hormones are really tightly linked with our carbohydrate intake, our injury risk. In the UK at the minute, all of our professional footballers are getting injured, and I think it's the same all around the world. And they're like, why is it? We've got a whole chapter on why are women like seems predisposed to be getting injured, and what can we do about it? Lots on concussion as well, like the gender gaps in concussion and subconcussion, how women respond to coaching differently to men. So a huge breadth of topics, but it's written in a really, really practical way with loads of great stories, all evidence-based. So it's fully referenced in the back, but the way it's written, it's a really easy read that's not gonna, you don't have to concentrate and take loads of notes. It should just kind of like be quite consumable. And we want our real belief is that women's bodies are holding them back right now, and we need to kind of like really help women understand their bodies so they don't hold them back, so they can be active and do the sport and physical activity that they want to be doing.
Fantastic. So when you were writing this book, co-writing this book with your other co-writers, what was the thing that you learned, perhaps in your research or in your writing, that just blew your mind wide open?
Oh, that's a really good question. I think it was the stuff on concussion. I think that really, really shocked us. I think that, you think you're a female health expert and you kind of like, you're doing all the female health bits, but then we started really exploring. There's lots of stuff happening in the UK, and I'm assuming it's the same over there, but it was all like these like 50, 60-year-old men who are now having Alzheimer's and dementia because of the sport they played as youngsters. And that's kind of like, there's loads of outrage and lawsuits being taken with that group. And we were going to conferences and we were listening to, whether it's schools conferences or scientific conferences, and people were kind of presenting the evidence on concussion. And we were like, this is all about men. Like, women play sport too. What's happening with women? And actually, when we went out and did the research and we looked, women are twice as likely as men to suffer from a non-contact concussion. So that's basically head to floor concussion. Yet boys are 1.5 times more likely to be removed from the field of play. So women are more likely to be concussed, yet we're not, but we're not removed, but boys are being removed far often than girls, because I think people just, because they don't clash heads and they don't kind of like, there's not a big kind of clash in the middle, people aren't spotting it. And nothing is being presented in a gendered way. It's all kind of like this, this guidance on return to play, but all around boys. And we know that actually women have much more severe symptoms and they take longer to return, but the guidance isn't reflecting that. And so that's we're on a bit of a mission with that one, to kind of really start opening up those conversations, because it's a huge duty of care issue. It's a huge issue that I was in the world of elite sport 15 years ago when I was on the British rowing team, and arguably you cannot blame the coaches of the system back then for really not considering any aspect of female health, because it wasn't being talked about. There wasn't that much out there. But now we know so much that it can't be seen as a nice to have or something that we'll do when we've got everything else right. It's like, no, do you know what? This is actually fundamental, and we need to start taking this really seriously.
And the research is telling us that the reason why women have more significant symptoms with concussion and post-concussion syndrome is because of the neck musculature. And I think it's incomplete. There's a much bigger picture there. It's not just she's got a weaker neck, so she's going to have more head injuries, right?
Yeah.
When I see that, it sort of incenses me a little bit.
Yeah, I know. So no one really knows, because no one's, there's very little research, as you say, but it's something to do with the neck and the lighter head. So it's just like our heads whip faster. So they whip faster, so the brain moves more. And that is the working theory at the minute. It's the brain moves more inside, so that's why the trauma is more. And really interestingly, when estrogen has a protective effect on the head, so where you are in your menstrual cycle really affects the symptoms that you are experiencing. Yet if a physician doesn't know that, they won't ask. They won't say, where are you in your menstrual cycle? Because that's really going to affect how we return you to training and playing.
Yeah, absolutely. And, this is one of the things I do clinically is I work with young athletes and correcting TBI. So I know this one really well. And what was really interesting for me, I've been doing that work for 12 years now. What was really interesting to me was I noticed that the young female hockey players versus the male hockey players, the females would have much more significant symptoms and they lasted longer. And so I got used to asking the question when I have a new concussion patient come in. I ask them, where were you in your menstrual cycle when you had your injury? Because it is a predictor of how well they're going to do afterwards, how they're going to do with the neuroplastic rehabs and this sort of thing, right? It's a really interesting conversation. And we have known that there's a progesterone link to things like knee injuries with athletes. And there's a VO2 max connection to the hormones as well. So I think the takeaway from this bit of the conversation is that we need way more research on what a woman's body does, not just with athletics, but the different pieces and parts of what happens, what can go wrong, etc. Because the truth is, most of the data, the medical data out there, is done with males and male bodies.
Yeah, and I think that we have this conversation all the time, and at the moment you hear a lot of, we need more research. We absolutely do need more research, but we can't. But my problem with saying that is that it therefore infers that we can't do anything until we get the research, and we know that that's going to be like 10 years away till we get anywhere near like having enough levels of research. So, but we know enough, and we actually need to, we need everybody in your position to be saying, where are you in your menstrual cycle, because that's going to affect this. Like, we can do a lot of work right now with with women's lived experiences of their bodies. Like, we know enough, don't we?
Oh, absolutely we do. You bet we do. You bet. And we've gone for so many decades without evidence-based, right? That's kind of the big thing in science right now. Well, that's fine, but that doesn't negate all the other things that have happened, right? Yeah, and it turns out the anecdotal stuff is really helpful too. So, which is what you're saying. It doesn't necessarily have to be in a paper for us to feel like it's actually happening, or that the paper recommends that we do something. It's the same thing if we're talking about HRT. By the way, let's go back to pelvic floor for a second, because man, you and I could go deep here. But concussion, the sex differences, the gender differences with concussion is such a fascinating topic. I am right there with you. So whatever you learned, send it over. I would love to see it.
Perfect.
Okay, so pelvic floor and HRT. Have you got anything to tell me about there?
The vaginal estrogen works.
Okay.
So the topical estrogen, does that make, like, so you have the systemic HRT that goes obviously around the whole body and has that, like, that's what women will take for their hot flushes and their brain fog and whatever else. It kind of works over the whole body. But as I said, the vagina and the pelvic floor is so reliant on estrogen that even that we need that micro dosing, that tiny dosing, really specifically delivered to that part of our body, and it makes a huge difference. And you can be on HRT and vaginal estrogen. You can not be on HRT and take vaginal estrogen. Those people that are worried about that, they've just made the decision they don't want to take HRT because of whatever risks they've associated with it. A year's worth of vaginal estrogen is the same as one daily dose of systemic HRT. So the dosage is teeny tiny. But I was working with a marathon runner, not a good one. She was admittedly not a good one. She just loved running, and every morning she went out for a run before work, and she loved it. And that was her way. That was her coping strategy. That was her way of like managing her life. It was all around her mental health. And she suddenly started experiencing these irresistible urges to go for a wee halfway through this run. And it was really bothering her because she's like, I just don't know when it's going to come on. I don't know if I'll be in the woods or by the road or in a park. I don't know where I'm going to be. And it's bothering me, and I'm stopping enjoying this running. So she started taking this vaginal estrogen, started to come to me and work and working on her pelvic floor health. And we were doing these exercises and everything was going brilliantly. And about 4 weeks in, she's like, started again. I don't know what's going on. I've just started leaking again. I was like, oh, that's a bit weird. And I'm sure you're the same. Like when you're working with a patient, you're like, this makes no sense, and you're kind of like throwing all these questions at them, and you're like going, I kind of a bit lost here. And then I said, you still taking your vaginal estrogen? She's like, no, I stopped that because I wasn't really sure if I should like carry on taking it. And I was like, that's it. I said, get that back in you, and honestly, we'll be off. And she did. And that was that. It's not going to be the solution, but it just gave her that bit more bladder support, a bit more bulking up down there, and it did the job. Yeah.
Fascinating. So for the women in perimenopause and menopause who have troubles with vaginal dryness, is there any pelvic floor thing there too?
No, I mean, I think the vaginal estrogen is a thing there. I mean, I don't think that the vaginal, the itchiness and the dryness, I mean, I think for the pelvic floor work, it's all around the prolapse. It really helps with the prolapse symptoms and the stress incontinence, and the urge incontinence is different. So the urge incontinence is not always because of pelvic floor dysfunction, so to speak. That's more of a behavioral thing, and that's a kind of your body, the cue to your body to relax your pelvic floor is not working. So your body, you putting your key in the door, or you're seeing a toilet, that is what is cueing your pelvic floor to relax and let go, and you're not on the toilet yet. So that is more a behavioral management. You need to take control back, and there's different strategies in place to use with that. But with vaginal dryness and itchiness, there's lots of brilliant moisturizers, but you need to get the right ones that are like pH balanced with your vagina, not the ones that are kind of oil. You want the ones that are aligned with the chemistry down there.
Yeah, and with an eye to the microbiome of the vagina as well.
Yes.
That's a really important one. Okay, so when I was doing some research recently about incontinence, I was surprised at the number of women that actually experience, and the number's not coming to me right now, so maybe if you've got it at the top of mind, you can share.
Yeah, so the general number is saying 1 in 3, but as I said at the start, like when you add in babies, aging, and exercise, it's 50% plus. And I think that the different studies, but it is definitely menopause it's 50% plus, and if you've had a child and you're exercising, it is going to be higher than that.
Okay. Well, when I saw that number, I thought, I have been talking to women about their hormonal health and the menopausal health for 20 years. And it is extremely rare for a woman to bring this up with me. That's how much of a taboo this is. This is how uncomfortable we feel about it. Even though you're in front of a paid expert, an expert that's being paid to help you with these issues, women are not bringing it up. So I am sure that this is vastly underreported, which is what you just just said. Yeah.
And so my theory on that is that menopause is inevitable, so it's supposed to happen. Your menstrual cycle is supposed to happen. So there's less of a taboo about talking about something that is supposed to be happening inside your body. When menstrual flow goes wrong, it's poo, sex, and wee. And that is, you're supposed to be able to do all those things. So if your body is not doing that, and you're a high achiever and you've kind of like nailed life and you're doing pretty well, like it's kind of like, oh, like how can I not be doing something as simple as this? And it's a kind of like, oh yeah, so I think there's that. And I also think that people are absolutely petrified of what the solution might be. And they might be like, oh, they're going to tell me I need to go for surgery. It's like, well, yeah. And there's been a lot of horror stories about kind of like what happens in those situations. It's like, no one can force you to have surgery, and there are a lot more options. There are a lot more options than that. But I think that people are really worried about like what the options may well be that they are presented with.
Yeah, I can see that. And I think we're sort of reaching a terminal point in our ancestral lines where we have built up this shame around our bodies, which most of it isn't even ours. We've just inherited it from our society, from our conditioning, from our parents, whatever, right? So I get that. That's where this underreporting is coming from. But I love what you just said. It's not just surgery. I mean, yeah, nobody wants to have surgery on their pelvic floor, but that's an option. But chances are there's a whole lot of other things that you can do for that.
And that's why when I was saying we need to get into prevention mode, when I had this saying that when your body is whispering to you, your options for treatment are huge. Can be anything, alternative, complementary, like talking therapies, medical, like you can kind of approach most problems in whichever way, shape or form you wish to. I know that's a huge generalization, but the options are huge. The louder that voice gets, the more problems you're having with your pelvic floor, the less options that are available to you, because it's getting bigger and bigger and bigger, and you become, it becomes much more medicalized. But at the start, like if it's just like, oh, I don't know, you're going to the toilet too often, or you're waking up at nighttime and going too many times, like it's a really conservative approach, which will be really effective. But I think the longer we leave it, then it becomes far less conservative, doesn't it? And we have to go pretty heavy on what those treatments might be.
Like so many things in female health, if we leave it, it's going to be a much bigger thing to deal with. And if the first time you hear that intuitive strike that says, okay, something's not right here, I need to go talk to somebody, listen to that. That intuition is so, so valuable. Like this conversation, Baz, it's been amazing. I have learned so much. And our friend Patty is so right. You and I need to sit and have a cocktail one day, my friend.
We do. We
do. And so please go out and get the Female Body Bible. I have started to read it. It is so well written. It is so accessible. It's chock full of really interesting facts about your body. I think it should be like it's like the operator's manual for a female body. So
it is,
yeah, and I know you've put a ton of work into it. So I thank you from the collective. I thank you for what you've the dent you've put in this big thing we call women's health. And so if people want to find, I've got one more question for you, but before I do ask that, if people want to find out more about you and your work and the book, where do they go?
So thewell-hq.com, that's where all of our information is on there. We've got loads of information about all the different parts of female health. There's information about the book, obviously, but you can find us all on there.
Fantastic. And I'll make sure those links are all in the show notes. And so here's my final question for you, which I ask everybody I interview. Don't worry, it's fun. It'll be fun. So knowing what you know now, what would you tell your younger self?
Trust your body.
I love that. Yes.
That's it. And it would be listen and trust your body. Listen to and trust your body. And I think that listening piece is a bit that there was nothing to listen to. Like I was like, nah, I didn't listen to anything. So I think that, but when it is telling you something, it knows what it's doing. But that is that's a vulnerable place, isn't it, to go to, because you're like, nah, that's not enough. My body is not enough. Like whatever it's telling me is not enough. So but I would absolutely, that's what I would say. Look, and I try and remind myself that every day, because I'm much better now, absolutely much better. I'm so much healthier than I was as an elite athlete and that kind of really highly driven, focused person. But you don't always get it right, do you? You kind of like, it's kind of, you have to keep you have to keep doing the work to get that right.
Yeah, it's a practice. Thank you, Baz Moffat, for coming on the Not Your Mother's Menopause.
My pleasure.
Thank you.
Thank you.
The views and nutritional advice expressed by Dr. Fiona Lovely are not intended to be a substitute for conventional medical service. If you have or suspect that you have a medical problem, promptly contact your healthcare provider. No information offered here should be interpreted as a diagnosis of any disease, nor an attempt to treat or prevent or cure any disease or condition. As with any new advice or program, you should always contact your healthcare provider prior to starting anything new. Thank you.